Okay, so we'll kick off. I know a few more might still be joining us, but I'll keep an eye on the waiting room. But hello, everyone, and thank you so much for joining us in our webinar today. This is a part of the Feminist Recovery Plan webinar series. My name is Rachel Paul, and I'm the Women's Sector Lobbyist with the Women's Resource and Development Agency. So today's event is in a part of a series of events, and this is the fourth event that's happened, the fourth event that we've had so far in this series. So I'm going to give a bit of an overview of what we're doing today and how this came about. So this event is being held in collaboration with the Women's Policy Group, the Women's Resource and Development Agency, Transgender NI, Alliance for Choice, and Migrant Centre NI. We will have different speakers from each of these organisations discussing different matters of additional health impacts from COVID. So this includes the implications of cancelled cancer screenings on groups that already face additional barriers to screening and the work that is ongoing already to try and tackle these barriers. The development of a new project on maternal advocacy and support in response to the lack of any perinatal mental health services or any adequate services in Northern Ireland. We'll also be covering the already abysmal provision of healthcare available to trans people and how this pandemic has worsened this. And we will be finishing up by talking about the hostile health environments faced by migrants and people of colour and how this has specifically impacted migrant women in Northern Ireland. So before we begin, I want to give a bit of a very brief summary of the health pillar of our plan, and I'll post links to all of this in the chat so that you can see it if you want while the webinar is on. So many of you already know this, but the Women's Policy Group for Northern Ireland is a group of women working in policy roles across Northern Ireland. And we have reps on this group from a wide range of organisations. And this is not just women's organisations, it also includes LGBT, trade unions, human rights organisations, migrant rights, and other campaigning feminist and advocacy roles that attend. We do a wide range of work together in responding to consultations, submitting evidence, publishing briefings, and the whole works really. And once COVID hit, I think it was really our biggest challenge to date was being able to respond to this. And because of the disproportionate impact of the pandemic on women globally, we decided that, from the early stages of the pandemic, that we needed to be focusing on providing the evidence of the disproportionate impact on women and how our government should respond to this. This involved creating briefings, articles, publishing statements, submitting evidence to as many committees as we could. But really what we found was as the months went on, there was little to no reference to the disproportionate impact of the pandemic on women from our elected representatives. And even where groups were being set up by the government to respond to the pandemic, we were being left out in almost every single circumstance and had to repeatedly ask to even be allowed in the room to present the evidence that we had been gathering. So we do know that the pandemic has created an unprecedented challenge across the world, and it has put a sharp focus on the value and importance of care work and our health and social care sectors more generally. And this includes care work that is both paid and unpaid. One of the most obvious parts of this pandemic was that it highlighted the essential nature and often precarious nature of the almost always low paid work that is dominated by women in these sectors. Women undertake the majority of this, and we know that women will bear the brunt of this crisis economically, socially, and in terms of health. And in our webinars up to now, we've explored the economic impact a bit more. We've looked at the social justice implications, and now we want to focus on health. So as the crisis impacts men and women differently, and in many cases deepens already existing inequalities that women face, we wanted to highlight that the key solutions to this, which have been around for decades, needed to be at the centre of any long-term response now, because this really is a turning point in how we respond to crisis. In particular, we were raising different concerns around gender segregation in labour markets, including the fact that over 70% of health and social care workers are women. When you look at social care alone, Northern Ireland has 79% women working here. The majority of paid and unpaid carers are women, over 80% of part-time workers are women, and over 70% of those ineligible for statutory sick pay are women. And what we're seeing now is that the majority of hospitality, retail, small businesses that employ women are being so severely hit with no response. We've also seen huge rises in domestic violence. There has been also no access to childcare or inclusion of childcare needs in any steps in moving forward. And other areas as well, where rural women were hit worse, where initially pregnant women were losing their rights to statutory maternity pay, where we've seen increased poverty, debt, and austerity still hurting women a decade on from the financial crash. We did have some small gains in our lobbying in the early days of the pandemic, but we still decided that we needed to create a comprehensive roadmap for policymakers to not only mitigate against these impacts that have been described, but to alleviate against pre-existing inequalities as we recover from this pandemic. So that's really how the Feminist Recovery Plan came about. And apologies to those of you on the call who have heard this about 20 times in the past few months. But that's just a bit of context of why it was created and what we've been doing with it. But the plan itself has a number of pillars. So we cover economic justice, health, social justice, equality, Brexit, a Bill of Rights, and international best practice. And in the health pillar specifically, we have information on mental health concerns due to COVID, the additional health pressures on women with caring responsibilities and dependence, the impact of cancelled cancer screenings and waiting lists, the impacts of poverty and austerity. We've looked at abortion, maternal health and bodily autonomy. We've looked at racialized inequalities due to hostile health environments, trans healthcare, and some specific implications for disabled women. Now, we could go into a huge amount of detail on any one of these topics and could dedicate a full webinar to even just one of these topics. But before I pass over to the speakers, I just wanted to raise a few of the points from the Feminist Recovery Plan that relates to their own areas of expertise. So poor mental health is one of the big ones, and evidence shows it is strongly associated with social and economic circumstances. This includes poverty, low quality work, unemployment, and inadequate housing. These are all areas that Northern Ireland has a particularly terrible record in. And when we look at the transgenerational trauma that is compounded from the Troubles, it just shows that this pandemic has had a particularly horrific impact on the mental health of people in Northern Ireland. We also know that there will be huge issues with additional levels of trauma due to the huge rise in domestic violence throughout the pandemic, an area that again has been totally ignored, and our elected representatives have not appointed any new funding to support services in regard to this. Cancer Research have estimated, and now this was back in June, most of these statistics have got worse, but they estimated that 2 million people across the UK were waiting for screening, tests and treatments since lockdown began. So that was from March until June. For every week that screening was paused, 7,000 people were not being referred for further tests, and an estimated 380 cancers were not being diagnosed. So this, coupled with the fact that many people can still not access screening, or people are afraid to access screening because of the pandemic, shows that it will have a much more long-term impact that will take, I would say, many, many years to overcome. So with increased waiting lists as well, this is something that is particularly bad in Northern Ireland. So in England and Scotland, 1 in 12 people are on elective waiting lists for over a year. In Northern Ireland, that is 1 in 5. So that equates to about pre-COVID, 130,000 people who were waiting more than a year for treatment. And we know that this is something that has increased dramatically since the pandemic hit. So these increased waiting lists leads to decreased quality of life and increases preventable disease and death. And just one example, rheumatology waiting lists in Northern Ireland are among the worst in Europe. At present, you have to wait 5 years to be seen by a rheumatologist, which is absolutely horrific and just shows the impact of these sort of diseases and how they're left to get worse. So this is just a very brief overview of the health pillar and what we've covered. I could, again, go into so much more detail, but instead I'm going to hand it over to our speakers who have much more expertise in these areas than I do. I will post links into the chat about all of the stuff I have just covered, but I'm going to just cover a bit about who we have speaking today. So first up, we're going to have Paula Murray from the Women's Resource and Development Agency, and Paula is going to discuss breast, cervical and bowel screening work that she does within WRDA. So she travels all across Northern Ireland in normal circumstances to increase awareness and to help break down barriers to screening. We also have Claire Anderson, who has joined WRDA recently, and she works on the maternal advocacy and support projects. So she will discuss the implications for perinatal mental health due to the pandemic and talk a bit more about the project more generally. Then we will have Alexa Moore, who is one of the directors of Transgender NI. Alexa is going to cover issues specific to trans people because it was one of the worst areas of being able to access healthcare before the pandemic, and it's just worsened. And if anything, we've just seen this being used as an excuse to strip away rights of trans people. This will be followed by Emma Campbell, co-convener of Alliance for Choice, who will cover the horrendous impact of the health minister's refusal to commission services and expect women to still travel to GB to access an abortion during a pandemic, which is just absolutely outrageous. And finally, we will have Kendall from Migrant Centre NI, who's going to discuss hostile health environments for migrants and racialised people in Northern Ireland. So at the end, we will have a bit of time for question and answer. So again, if you can send them to me in the chat, that would be great. So I'm going to hand it over to Paula.
Hi, I'm just going to share the screen, everybody, okay? So, hi, my name is Paula Murray. I'm the Training and Development Outreach Worker at Women's Resource and Development Agency. Thank you for inviting me here, Rachel. I hope I don't repeat some of the points that you made. I possibly will. Anyway, as I say, I would go out and I would deliver the breast, cervical and bowel screening awareness session. WRDA, I should say in the slide, have been contracted by the PHA to undertake a programme of work to raise awareness of the breast, cervical and bowel screening programmes in Northern Ireland and to promote informed choice among individuals from communities who historically have a lower uptake of cancer screening that's compared to the rest of the population. I'm going to talk a wee bit about the breast, cervical and bowel screening awareness programme and just the impact of the pausing of the screening programmes and where we're sitting now, the waiting lists and the fear that people have now about engaging with the health services because of COVID. First of all, before I go any further, congratulations to the Women's Policy Group on the Feminist Recovery Plan. Very in-depth and very clear and concise. So for everybody that was involved, very well done. Okay, so I've said about the programme. WRDA, we also give us a mention in the recovery plan of our programme and the recommendation for the important work that we do. So thank you very much for that. So the breast, cervical and bowel screening awareness programme, Women's Resource and Development Agencies, our awareness screening programme, was designed to tackle health inequalities. The programme is intended to inform participants of the screening services in Northern Ireland and to give them the confidence necessary to access these services. Okay, so screening programmes are free and everybody is eligible. Well, everybody within an age group is eligible. So all women from the age of 50 to 70 are eligible for breast screening. Women aged 25 to 64 are eligible for cervical screening, and women and men aged 60 to 74 are eligible for bowel screening. It is often the case that the most marginalised groups are the ones with the lower uptake of the screening services. Screening programmes and early intervention save lives, improve health and enable choice. Breast cancer screening saves about 1,300 lives each year in the UK. Cervical screening can prevent up to 75% of cervical cancers from developing. And each year in Northern Ireland, 420 people die from bowel cancer. Bowel cancer would be the second most common type of cancer in Northern Ireland. And as you can see there, if it is detected at an early stage, it can be 90% successful, the outcome. Screening also enables choice. It is your choice whether or not you have screening. So the groups that WRDA engage with are the groups that are less likely to access the screening services. And you can see here the list of groups that we would go out and engage with, but this is not limited. You know, there is a wide range of groups that we would go out to. It is people from the most marginalised communities, and these are the communities and the people that are most difficult for us to reach. So there has been research to show that demographic and socioeconomic factors are very much associated with poor uptake. Evidence shows cancer incidence is 15% higher in the most deprived communities. So when we go out to the groups, and our sessions are very interactive, and it is the participants, their session. So we do take on board all of their input. And as we always stress, you know, when we're out there delivering, we're delivering the information, but we're learning from the women, we're learning from the people in the groups. They're the ones that inform us. So the barriers to cancer screening, fear. A lot of people attending for screening don't go, not because they don't want to go. There's a lot of, as I said, barriers in the way. Some people just aren't able to access the screening. We have mobility issues. I was out with a group, and a woman who was very dependent on an electric wheelchair went for her screening, and unfortunately, because of the electric wheelchair, it couldn't be positioned at the screening machine, so the woman could be x-rayed. And she did want to be screened, and she was very disappointed, you know. But in that group, we were able to talk, and another woman was able to say similar thing happened to her, and she had been able to borrow an ordinary wheelchair and have support with her, and she was able to get her screening. And it's wee bits of information that are shared within the sessions that we don't have all the answers, but it's people talking about their experiences and maybe how they get around the different barriers. There's not always a way to get around the barriers, but this is why we're out there. We want to be able to find out what's going on, the inequalities, and to bring the information back and you know, put it forward to the PHA, to different bodies of what is happening and why people aren't accessing the screening. So we also have inconvenient times and locations. And again, as very much detailed in the Feminist Recovery Plan, the challenges to carers. And we know this because we would deliver the awareness information to a lot of carer groups. And it is lack of support. Their time is very much took looking after others, and their health comes second. And so again, if we can find ways that maybe they, you know, within their group, and there is support and ways that, you know, we get the message across, it is about prioritizing your health. You're really, really important. And if you're not there, who is going to take over your current responsibilities for your family member or your loved one? Also, the one that we're all dealing with at the minute, COVID-19. So on top of all the other barriers, the other things that are stopping and preventing people from getting screened, we had COVID-19. So the impact of COVID. So the population screening from the second week in March was paused. Routine breast screening, bowel cancer screening, and cervical screening. As highlighted, and Rachel, you've already mentioned this again, it is in the recovery plan, that every week that the screening was paused, 7,000 people aren't being referred for further tests, and 380 cancers aren't being diagnosed. The Department of Health restored the screening programmes, as you can see, in the summer, and we started with the cervical in June, the routine breast screening in July, and then the bowel cancer screening in August. And again, very much alluded to in the Feminist Recovery Plan, this pause has resulted in a backlog. The PHA have also acknowledged this. And even now that the screening's up and running, there is social distance, there's infection control measures. These are all slowing things up. So it is going to be a very, very long time. And just what you said, Rachel, yes, it will be a long time before we get back to what was classed as normal screening. Due to COVID, there is a fear of engaging with healthcare services. And we all know this, there is a real fear out there. None of us want to be exposed to COVID. None of us want to get COVID. So a lot of people are avoiding, maybe if they have symptoms or concerns that they normally would have went to their doctor with, they're now not, they're holding back. And this again is going to have a long-term impact on people's health. And it's just compounding the whole situation that we're dealing with at the minute, adding to all the backlogs and the waiting lists. The information that the PHA sent us, and as you can see on the slide, figures show that since cervical screening reopened in July, there was 110, now that was from July to October, so there's probably, this has maybe changed slightly now in November. There was 110,000 invitation letters sent out, and of that 110,000, only 10% of people that got them made their appointments. So there is approximately 7,000 women a year who pre-cancer cells can be detected at the screening, and these can be removed at colposcopy. And again, this is all now being missed. So it is, as the quote that we got from a doctor that sent this information to the PHA, these pre-cancer cells are silently progressing. So WRDA screening awareness workshops. So what we do is we deliver information on the importance of participants prioritising their own health, why screening is offered, who is offered screening, what will happen at the screening appointment, the benefits and risks of screening. This is about informed choice. There is limitations to screening. The potential outcomes, including types of results, further tests and treatment, and awareness, very much about awareness, knowing your own body, recognising changes or signs and symptoms, and don't ignore them. Go immediately to your GP. Both the content and delivery of our breast, cervical and bowel screening awareness sessions are delivered and shaped by an understanding of the content, and the delivery is shaped by an understanding of the reality of people's lives. So since COVID, we have adapted our workshops. We weren't able to get out. Again, we were out, we're delivering awareness, we're delivering information on the cancer screening services available. And from March to August, we couldn't go out with that information. We can't give information on something that isn't available. It only adds to people's concern, their stress, and people are already worried that they've missed their appointments. So once screening was up and running, we have been trying to get out there, and we have been delivering our sessions by Zoom and webinars. This has worked very well for some groups, but a lot of groups do not have the IT, or they're lacking in the IT skills. And the other thing is, to deliver by Zoom and all is brilliant, but it isn't the social interaction that the groups that we would go out to need. Going out, meeting with your group, having a cup of tea, this is as much for their health and well-being as anything. And so again, we are delighted to be able to say that we, assessing the situation as it sits, I know we are in a second wave, but we're assessing the situation, and we this month have decided, when possible, we will be going out to do face-to-face deliveries with the groups that we work with. WRDA work with others. We work to build relationships. We take advice from key workers, from the health and social care staff. We need to be advised on, how we address these inequalities, and we support the health system in reducing the inequalities. WRDA, we want to make sure that screening and health services are, equitable for everybody to access. We have we do work on different initiatives within the screening services, and I have just highlighted a couple. We took part last year in the Southern Trust in the Institute for Health Improvement pilot. This pilot was to identify the needs of women with learning disability and disabilities in advance of attending further screening, so that any changes or adjustments that were needed before they had their screening, that these could be made. This has now, it was a pilot for a year, it has been extended, and we are hoping to hear word of when we can get back up and running with this. We also have linked very closely with the screening units. We have worked for the past few years very closely with Linen Street and the Informed Choice Lead. So if we're out with a group, and maybe within that group there is a few women that maybe for whatever reason have missed their screening, haven't been screened for a while, we can link them up with the Informed Choice Lead at Linen Street, and she is able to organise for them a special clinic where they can go out together in a group and be screened together. Now, at the minute, with social distancing and the different measures that are put in place for, you know, infection control. But again, this is something we're hoping once we're out, up and running, that these things will again take off. This is an initiative that we have rolled out to the other 3 health trusts. As I say, we'd already worked at Linen Street, which covered Belfast and South Eastern. Anyway, thank you all very much, and I hope you got all that. I did get a bit tongue-tied, but look, any questions or anything, I will be here after, you know, I'll be here throughout. And as I say, we're here to deliver the screening awareness. We know how well it works, and if anybody is interested, I'd be more than happy to get that arranged. Thank you.
Thank you so much, Paula. And I think it's a really useful overview of the work that you have been doing both before the pandemic and during it. And it really just highlights some of the barriers that exist for women. I did get a note from Catherine, who also works at WRDA, to state that women over 70 can also arrange their own appointments for mammograms. So it's just something useful. But if any of the groups here today would be interested in learning any more about this, or if you have any groups that you think will benefit from the training, the contact details were there, but I can send them out to people if you want them as well.
Yes, and Rachel, thank you, Catherine. I should have mentioned that, but that is, with breast cancer, your risk does increase with age, and although women aren't automatically invited after the age of 70, really, it is important. You know, they are encouraged to still make their own appointment, and it is important to do that. Thank you.
Thank you so much, Paula. So we're going to go to our next speaker now, Claire Anderson. So Claire has recently taken up a post in WRDA, and she's working on the Maternal Advocacy and Support Programme. So this was a campaign that had a pilot programme last year, and they worked with a range of women's centres and supporting women with their perinatal mental health. So I'm going to hand over to Claire now, who's going to talk to us for about 10 minutes. Thanks, Claire.
Thanks a million. Hi everyone, it's really great to be here today to tell you about this wonderful new project that will be just such a great support to women within community. So as Rachel mentioned, following the success of the pilot, we have gained funding from the Big Lottery Community Fund for 3 years to roll this project out to 8 different women's centres. So we'll be working in partnership with Windsor, Falls, Footprints, Atlas and Lisburn, Greenway, Ballybean, Women's Centre Derry and Strathfoyle, and many of them were involved in the pilot, but this it will be slightly different in that we have a project worker that will be assigned and able to facilitate the groups within the women's centres. So first of all, for year 1 of the project, the focus will be very much on peer support and developing peer support groups within the women's centres where women can learn to support each other, and this will be facilitated by the project worker, and they can develop skills to keep well, focusing very much on self-development. There will also be space for follow-up support outside the groups by the project worker, you know, making referrals. We're very keen to establish referral pathways really from community midwife teams, from health visitors working in the area, so that women can receive support within their local women's centre, and hopefully working closely with the Sure Start. So just building up those networks so that the peer support group is very much a visible resource within the community, located in the women's centre, where women can be supported. So that's very much the focus on year one, and we'll run over the 3-year project. But in year 2 of the project, we will focus more so on the campaign element, where women can really express their voice within the peer support group, but also get involved in the campaign for change and for better services. Women will also have the opportunity, if they want to train as peer supporters and to facilitate the group. So throughout the project, we will be working very closely with the WRDA NI, who will provide training and support for the project workers, and they can also provide that for women. So we really want to value that lived experience. So all the MAS groups are located in disadvantaged areas, which really about empowering women and giving women that opportunity and confidence to use their voice and experience, and they can feel safe to do so without judgment. We also aim to reduce the stigma in this area of perinatal mental health. I also just want to talk about the current services. In Northern Ireland, we have the worst services for perinatal mental health in the UK or Ireland at present. We have 5 trusts, but there are only a few specialists based within one trust, within the Belfast Trust, in perinatal mental health. Now that is changing, thankfully, due to much campaigning within this area. So the Mental Health Action Plan have agreed community services with specialist teams. So that was to be up and running, but it has been delayed. And again, that's no doubt undoubtedly been impacted by COVID, but there has been just some delay in agreeing some of the finer plans and details. But we have been informed that it is in the final stages now, and hopefully those specialist teams will be up and running early in the new year. So that's a massive advantage for women living in Northern Ireland who currently don't have that service. Like that service would be for women maybe in the more severe end. So that's where the support groups, the peer support groups, are so important for women who maybe don't meet the criteria for the specialist service. In addition, in Northern Ireland, we have no mother and baby unit. So a mom who does need to go into hospital will have to go to a general psychiatric ward. So again, we will be involving the women in the campaign for change and to get this up and running in Northern Ireland so that moms can be supported in hospital with their baby. So what is the impact of COVID? The impact, of course, no doubt the delay in specialist services, but also there is anticipated to be an increase in referrals in perinatal mental health. This is a time of global isolation and mental health concern. So maternal issues are obviously impacted, and there is such a sense of social isolation. People really can't access their usual support networks, such as family support, and even attending a parent and toddler group, engaging in things that might have otherwise improved their mental health. That hasn't been able to happen, as well as the additional financial concerns and other factors. So really, many professionals have anticipated potentially an epidemic of maternal mental health concerns because this is such a time of isolation. So this is needed even more so, these services are needed, but also highlighting just the importance of the peer support. So the specialist services, the mother and baby unit, but the peer support. So our action for the future is that we would like to see the specialist services set up as soon as possible. And we would anticipate hopefully that this will be in the new year. This will make a real difference to mums that need this service, that they can get this specialist team, the specialist support that isn't available at present, but isn't available in other parts of the UK and some parts of Ireland. Also, we'd like to kind of create community awareness of the issue of perinatal mental health. And we hope that the MAS project will create that visibility, being located in women's centres within community. We aim to increase through the women and kind of giving them that, encouraging them to express their voice, reduce the stigma in this area, and that moms do, need support, but also to roll out that peer support model, to value the peer support model within community for women who need it and who maybe don't meet the criteria for the specialist services, just so that they can get involved within the women's centres and keeping themselves well and able to fulfil their potential for the future.
Thank you so much, Claire. And I just think it's really important that we were able to cover this new project today because it is so crucial. It was crucial before COVID and it's even more crucial now. And for those that don't know, in Northern Ireland, suicide is the biggest killer of new mums. And tragically, we did see a death of a new mum recently in Northern Ireland. And one of the common themes that we will see across all the speakers today is that the support and health provisions that we're talking about aren't available in Northern Ireland, but are available in GB and in the Republic of Ireland. So I really think when we're trying to recover from this pandemic, we need to be asking for better because it's not good enough anymore that we're so far behind in everything in Northern Ireland. There is also a campaign that we're supporting in WRDA. It's called Mothers Matter. And they're calling for the rights of pregnant people and their partners to be considered. So they want for those who are pregnant and their partners to be considered as one unit so that they can attend scans, labour, birthing, appointments afterwards as well. And we'll be putting more information out on our social media next week about that campaign.
Yeah, I meant to mention that, Rachel, just about as well as the social isolation, just about kind of the maternity restrictions within the hospital and women often having to go through experiences largely alone. It's going to have an impact in the future and the need for perinatal mental health services.
Definitely, and it's just such a huge issue, and it's again one of those oversights in the response to the pandemic where the complex needs of some women are just being ignored. I know members of my own family who have had drastically changed birth plans last minute, had no support, had emergency C-sections, had no support afterwards either, and are really struggling right now. So it's thank you so much, Claire, for giving us an overview. And for anyone that doesn't know, Claire only started a few months ago and look at how much that she has done since. So please do get in touch with me if you want to find out more about any of the programs that have been mentioned so far. Thank you, Claire. So I'm going to go to our next speaker then. So our next speaker is Alexa Moore, and Alexa is one of the directors of Transgender NI. Alexa is also a member of the Women's Policy Group and contributed significantly to the development of the Feminist Recovery Plan. So over to you, Alexa, to give a bit of an overview about the specific implications for trans women and trans healthcare more generally.
Hi, thank you so much. Thanks for inviting me along to speak today. As Rachel said at the start of this session, I think we could spend about an hour on each of these individual topics. Like, I know that I could spend 3 hours talking about trans healthcare. There's so much in it, there's the specifics of gender affirming healthcare. For like specific care for trans people. There's also access to mental health care. There's also access to mainstream healthcare. So I'm going to try and cover some issues with kind of across the board here today, just to give you a brief overview of the current situation. So pre-COVID, if we're looking at kind of what was happening with gender affirming care, which is how we refer to transition related healthcare. If we're looking about kind of what happened pre-COVID, around January 2018, the only adult gender affirming service in Northern Ireland, which is based in the Brackenburn Clinic, they stopped accepting new patients. So that was over 2.5 years ago now that new patients stopped being accepted into that service. It was operating on a one-in, one-out system. And the waiting lists were just getting completely out of control. It is a similar story for the under 18 service, except it has continued running for the past 2.5 years. just because it's an actual commission service, and it's a little bit in more of a little bit of a stable position than the adult service. Now, these issues and this kind of crisis in trans healthcare has come about not just because of, you know, lack of funding or lack of staff willing to work in it, or any kind of number of those. It's a combination of those, plus the fact that transition-related healthcare is based in a model of psychosexual care. It is essentially mental health care, and trans identity is, for the large part, treated as a mental disorder. Now, in the kind of global context, the World Health Organization declassified trans identity as a mental disorder last year in 2019. They moved it from mental health into sexual health, and the diagnosis is specifically gender incongruence. So now we've moved away from diagnosing the identity to the kind of, you know, the impacts of the dysphoria or the discomfort that comes about as a result of being trans. So that's kind of the baseline for what the model looks like. How it actually impacts trans people is a whole other ball game, really, because the reality and the impact of having it framed within mental health is that you have a situation where a clinician who is, for the, you know, the vast majority of whom are cisgender, who aren't trans, you have them in a position of power over trans people to decide essentially whether or not they are really trans and whether or not they qualify for access to gender affirming treatment. Now, obviously that power dynamic creates a situation where the trans person in question is going to be engaging with that service in a way in which maximizes their chance of accessing gender affirming care. Because obviously the, you know, people who go to these services, you know, usually they will have things in mind for what they want. They will want maybe hormones or facial feminization surgery or speech and language therapy or whatever the case may be. But for all trans people, we're funneled down this one pathway, this one kind of treatment plan that is purported to work for all of us, even though every person's an individual, every kind of, you know, it's the same for pregnant people, kind of going through pregnancy and birth. Every experience of that is individual. Every person's needs are individual, and so you can't simply follow along this preset pathway to suit everyone. It just doesn't work. And the reality of the kind of current services is that that pathway is incredibly stigmatizing. It is often traumatizing for trans people to have to go through. We have heard of young people being kind of interrogated around their sexual preferences, their masturbatory habits, you know, questions and lines of interrogation that would traumatize the someone who is even, you know, kind of stable and mentally well and didn't need any kind of additional support. But especially for those neurodivergent people going through those services, especially for disabled folks going through those services, it can be, you know, it can cause and raise massive issues around kind of, you know, access and what you call it, being able to speak openly about your experience without fear of, for instance, being discharged or being removed from a waiting list or whatever the case may be. So that's kind of gender affirming care before COVID. That's before the pandemic hit. Now, you know, there was a review kind of commissioned sometime last year, close to October, November time. Obviously, due to COVID, that hasn't really moved that much. It hasn't really made much progress. And to be honest, trans inclusion and representation and voices in that review is significantly lacking. And it's not because of a lack of pressure from ourselves or other trans and LGBT organizations. It's because of a lack of willingness on the part of the department and the Health and Social Care Board to meaningfully engage with trans communities and put the work in there. And obviously all of these issues are having a massive impact on the community health and well-being. You know, whenever you, it's a similar kind of situation with abortion, as Emma is going to talk about. Whenever you remove a service, whenever you don't provide a service or leave people without access to care that they need, that care doesn't stop happening. It just continues happening in an unregulated way. So what we're seeing in Northern Ireland is a large number of trans people self-medicating, accessing hormone care privately, or going online and purchasing it themselves. We see people crowdfunding for their care in Northern Ireland in a similar way that we would see people in America crowdfund for basic healthcare and human rights. It really is having a detrimental impact on the community and is causing a significant amount of harm. What we're calling for from the department is not just for the review to keep going and for the commissioning of better services, but also to recognise that while that commissioning is going on, while that review is going on, trans people are still suffering. There's still significant kind of, you know, a significant number of people who are, for instance, on hormones that they're not being monitored for. Not for lack of trying. Again, they may have went to their GP and asked for blood tests. They may have went to the endocrinology clinic and asked for support, but in the vast majority of cases, people are turned away. You know, because there's a lack of expertise, or, you know, because doctors don't know how to interpret blood test results, or whatever the case may be. There is just one excuse or another for not providing care, for not providing support. And that isn't a neutral thing. You know, the decision to not provide care is as impactful as the decision to provide care. And what we're seeing within trans communities is a general unwillingness based on their experiences with GPs, based on their experiences with gender affirming services and practitioners within those, a general unwillingness to engage in mainstream healthcare services as well. Things like accessing mental health support, sexual health clinics, and general just healthcare checkups. You see, we kind of within the community, we talk a lot about the trans broken arm syndrome, which is basically, you know, you go to your GP with a broken arm and the GP kind of turns around and says, oh, well, you know, that might be related to the transition, or, you know, we might have to send you up to the gender identity clinic for that one, when obviously it's completely unrelated. I was in a panel discussion with a colleague in England yesterday who actually kind of worked with someone who had experienced the trans broken arm syndrome, went in with a sore arm and was told, oh, well, that's probably the testosterone that you're on. There's just a very, very clear lack of understanding in its entirety of trans people's healthcare. There's a lack of awareness of the different ways in which hormone treatment and stuff like that can impact on people's care. And this has an impact even whenever you're linking into, you know, what Paula was talking about with regards to screening care for trans people. You know, trans women, for instance, depending on their point of transition, may need both a bowel cancer screening and a breast cancer screening. They almost certainly won't be invited for both. And so what you're seeing is, again, when you have systems, when you have services and entire kind of healthcare bodies that are just built around this binary idea of gender, this binary kind of male-female kind of coding of care, which just simply doesn't work when you start to kind of take into account the diversity of people's physiology and records and their expressions within trans communities. Things like cervical cancer smears and testing for trans men in that regard, you know, is lagging so far behind where it should be, and people are missing out on a significant amount of care. I'm probably going to wrap it up there because, you know, if I don't, I will just keep going. I will, you know, the reality is that this trans healthcare is such a nebulous topic. There is always going to be another issue to unpack. And until trans people, until minority voices start being prioritized in kind of discussions around healthcare, discussions around, for instance, the recovery from the coronavirus pandemic, these things won't meaningfully change. So we're going to keep working on kind of fighting for healthcare advocacy. Hopefully there'll be a project that we'll be able to reveal relatively soon. We're looking to get a kind of dedicated healthcare support and advocacy officer to work specifically with trans communities and support them in accessing that care. That work is currently being done by a very small team of people whose job it is not, but kind of, you know, have taken on those roles. So yeah, we're hoping to keep pushing on this, and thank you all very much for attending today, and I hope you found it interesting.
Thank you so much, Alexa, and just an incredibly interesting overview, but it's also just harrowing to see that when we look at groups that are already marginalised, their identities are what's being used against them to create further marginalisation and more barriers. So it just shows the impact of this on women, on trans communities, on different groups who are disabled, migrant, all of it. There's just a common theme across all of our speakers today that those who are most marginalised, it's getting worse because of COVID. And again, what exists in GB or the Republic of Ireland doesn't apply in Northern Ireland, which is just incredibly frustrating. And I know that Transgender NI, you know, you work so closely with us, the Women's Policy Group, and we ensure that all of our work that we put out is trans inclusive. But I know you've worked with our breast, cervical and bowel screening team as well. I know you've worked with Paula and others on tackling some of these barriers like trans men accessing cervical screening and more. So I thank you so much again. And the work that you do is just so inspiring. So I'm going to go to our next speaker now, another equally inspiring woman, Emma Campbell. So Emma is one of the co-conveners of Alliance for Choice. And on a side note, Emma also created our lovely snazzy branding for the webinar series. So she's also a very talented artist. So I'm going to hand it over to you, Emma.
Okay, can everybody hear me okay? Just checking this. Okay, great.
Yeah.
I'm going to share the screen. Here we go. So I'm specifically talking about the health part of the Alliance for Choice campaigning, and obviously abortion falls quite squarely into the health needs and health pillars for the Feminist Recovery Plan. Like many of the previous speakers and like Alexa, there's so much detail that I could go into, but I'm going to try and focus it down to one particular issue, which is telemedicine really today. The main asks that we want from the Feminist Recovery Plan with regards to COVID are urgent telemedicine for early medical abortion, which is the abortion with pills, commissioning of sexual and reproductive health services across Northern Ireland to make sure that there's equal access for everyone, even in rural areas, to commission the free, safe, legal and local abortion services accessible to everyone who needs them. So that includes, I know every single presenter has talked about people in marginalised situations who become even more marginalised during COVID, and that's no different for abortion. And also, this is because there is a lack of commissioning based on the fantastic law that we got this time last year. Standardised, evidence-based relationship and sex education in line with CEDAW. Again, that was proposed as part of the legislation last year, and also ring-fenced funding for any organisations who offer non-directive sexual and reproductive health services and support. So we really believe at Alliance for Choice that abortion is central to women's health and social outcomes. It's not just a niche health and justice concern. 1 in 3 women will have at least one abortion in their lifetime in most countries in Western Europe. It's a more common procedure than wisdom tooth removal and appendix removal. So every single family in Northern Ireland will be impacted by abortion, whether directly or whether they've helped someone or loved someone who's had an abortion. Despite the pervasiveness of abortion, anti-abortion decision makers wish to keep it hidden away. And the people with the power to allow the full access are blocking appropriate funding. They're blocking any information at all on the services that are even available right now, blocking any training for staff. They're blocking general access to 1/6 of the adult population. They're creating dangerous political precedents in order to maintain their inaction, which is harmful to transparent and representative governance, especially with regard to the executive decision making. So the veto that they have blocked any commissioning so far on abortion services mimics exactly what the DUP did last night by vetoing, or the night before, who knows, we've been waiting so long, on the provisions for lockdown guidelines. So what they're doing is effectively using mechanisms that are supposed to protect those who are most disadvantaged, and instead using that to kind of further their ideological agenda. For us, the particular COVID flashpoints are firstly that Northern Ireland, again, like many of the previous presentations, Northern Ireland is an outlier as the only place in the UK and Ireland without any commissioned abortion provision. And this is despite, from the 21st of October last year, we have a better law in Northern Ireland than they do in the Republic of Ireland and than they do in England, Wales or Scotland. Northern Ireland Health Trusts set up services across initially 3 health trusts. And what the Department of Health did, they didn't just not commission, they actively tried to bar those health trusts from opening their doors. And it was only when organisations like ourselves and Doctors for Choice threatened legal action that they changed their mind and allowed the services to continue. The DUP has continually tried to undermine abortion legislation through various different manoeuvres, most recently by using disability rights in a manipulative move to try and undermine the look of support for what we have. The Northern Ireland office and the Department of Health were asking people to travel to England at the height of a pandemic. Now that suggestion of travel kind of quieted a little bit when the trusts began their services. But as of the beginning of October this year, the Northern Trust, which kind of includes the whole Northwest region, a lot of rural areas, and at the time Derry, one of the most infectious places in the whole of the UK and Ireland, had no services. So they were asking people from that area of Northern Ireland to travel to Liverpool, because none of the other trusts in Northern Ireland, without the funding available that would have been through commissioning, had the resources, staff or capacity to take on any new patients. What that has resulted in is a 28% increase in women from Northern Ireland using online pill services from Women on Web and Women Help Women. Now these services are safe and they're done with consultation, but you have to pay. They're around 70 to 90 euros each time, whereas they should be able to access those services free on the NHS. And secondly, women and pregnant people were promised full, free, safe and legal access in Northern Ireland on the 21st of October last year, and it just hasn't been delivered. So the World Health Organization commits to the idea that reproductive and sexual health services are absolutely essential during COVID. If you can imagine, much the same with maternal health services, abortion is very time sensitive, and obviously the sooner you can access services, the better. In June 2020, they recommended that all countries where possible should minimize any facility visits and provider client contacts through the use of telemedicine and self-management approaches. I'm sorry, I'm exasperated. The Northern Ireland office had the power to add telemedicine into the Northern Ireland regulations in March this year. They had the power before the regulations were laid down in front of Parliament, and they refused. And instead they gave the power to commission telemedicine to our head of Department of Health, who's currently Robin Swan, and who was seen attending the Darkest Day protest a few days after the law was introduced in Northern Ireland. So he's an avowedly anti-choice minister, and they gave him the power for telemedicine commissioning when they still had the power to do it before the regulations were set. We again stand as an outlier. Ireland was the first country in the whole of Western Europe to have access to telemedicine due to COVID-19. England followed very close behind a week after we asked for it to be in the regulations, and it was refused. We still, 9 months later, have no legal access to telemedicine. Telemedicine is vital for abortions, for people who are self-isolating, for people who are living with family members who are self-isolating, for people who have COVID. For people with disabilities who, like the breast screening presentation mentioned, not all the clinic facilities are disabled friendly. Not all abortion facilities are disabled friendly, and telemedicine is a much easier way for people to have access to the pills at home. There's also issues like people in abusive situations. Quite a lot of the people that contact Alliance for Choice directly, for instance, don't want to admit to their abusive partners that they're having an abortion, so they want to try and pretend that it's a miscarriage. You can't do that if you have to unnecessarily attend a clinic at the height of COVID. So just a little explainer for those who might not know what EMA or early medical abortion pills are. They are 5 tablets. This is what an abortion looks like. That blister pack is what an abortion looks like for 90% of people who access abortions. It's 5 tablets. You take 1 tablet mifepristone, which stops the production of progesterone, and then 24 hours later, you take 4 tablets of misoprostol in between your gums and your inner cheek. Now, these are incredibly cheap medicines. They cost about $5 to make worldwide. They have been used to save hundreds of thousands of lives in the last 10 years globally. And yet our government wants to make people go to the clinic to take the first one, and then you can already take the second 4 at home, but they won't allow telemedicine for the first one. It doesn't make any sense. It just shows you how little they know about the process of early medical abortion, and it completely contravenes the World Health Organization recommendations up to 13 weeks of pregnancy, even before COVID struck. Now we and we have been doing a lot of work on the education around the abortion pills, because we know it won't be happening anywhere else in Northern Ireland. So once a month we run an abortion pill session. If anybody wants to attend, they're normally either a Wednesday evening or a Saturday morning, and we tell people exactly what the abortion pills are, how to use them, where to get them, what side effects to look for, and so on. The reason our law changed was because of a really kind of groundbreaking CEDAW inquiry. There's only been 4 CEDAW inquiries on abortion in the world, and the UK was subject to this between 2016 and 2018. And the committee found that the state party, which is Westminster, were responsible for grave violations under the convention, considering that the state's criminal law compels us, in cases of severe fetal impairment, including fetal anomaly, victims of rape or incest, to carry pregnancies to full term, subjecting people to severe physical and mental anguish constituting gender-based violence against women, and also systematic violations of rights under the convention, considering that the state party deliberately criminalises abortion and pursues a highly restrictive policy on accessing abortion, thereby compelling women to carry pregnancies to full term, travel outside Northern Ireland to undergo legal abortions, or self-administer abortifacients. The law we had on the 21st of October was supposed to stop this, and all 3 of these things are still happening. This is still in contravention of our duties according to CEDAW and international human rights. Many people with severe fetal anomalies are still being forced to travel to England at the height of a pandemic with wanted pregnancies with really, really heartbreaking diagnosis, just because there's no commissioning. So trusts on their own don't have the time, facilities, or so forth for doctors and surgeons for the much more complex cases that you get in a second trimester abortion. People are still traveling to Liverpool. The British Pregnancy Advisory Service said that they're still seeing far too many people from Northern Ireland traveling over when they should be able to access it in Northern Ireland. Normally, at the minute, people can only really access in Northern Ireland up to 10 weeks. So we're still seeing far too many of these clear breaches of human rights in Northern Ireland. So our current law in Northern Ireland is supposed to be on request up to 12 weeks, which means you don't need a reason, you just need to ask. From 12 to 24 weeks, if continuing with the pregnancy is more risky than ending it. And for most people, that's true. Now, we have to bear in mind that 90% or 9 in 10 pregnancies that end in abortion are before 12 weeks. So most people pretty much as soon as they realise they're pregnant and don't want to be, try and access an abortion. Now, previously in Northern Ireland, when it was completely illegal, that was much later. So there's very, very clear evidence that in countries where the restrictions are more severe, that abortions tend to happen later. But it needs to be for people in that second trimester, because the anomaly screenings only happen at 20 to 22 weeks, and then people need to decide what they want to do after that screening. We have, according to the law, the ability for abortions post 24 weeks if there's a grave illness of the person carrying the pregnancy, or if there's a serious fetal anomaly. So when we're talking about serious fetal anomaly, this isn't what the anti-choice lobby are talking about, Down syndrome or a hair lip. We're talking about cases where there's no skull, where there's ribs growing outside of the body, where there's complex and comorbidities diagnosed at a 20-week scan. This is really heartbreaking for people, and the fact that they're still having to travel to places like Liverpool and ask airlines in COVID if they can carry fetal remains back in cool boxes is completely unacceptable. Nobody should be having to travel with our law. It just shouldn't be happening. What the reality is in Northern Ireland is that on-request abortions are only happening up to 10 weeks with the provision in the early medical abortion clinics, and only in some trusts. For 12 to 24 weeks, what we're finding is that people need really serious life-threatening illnesses in order to prove that they qualify for an abortion, and that's not what the law says. And we have no evidence of any post-24 abortions, although that could also be because they're very rare. So they tend to be less than 1%. So there might only be 2 a year, for instance. But there is no, the doctors who set up the services, it was a dedicated group of doctors and nurses who set up those services in the trusts without the commission of the Department of Health, which is a really unusual way for them to have to work. And they're trying their best, but loads of them, as soon as they're not redeployed anymore, they're going to have to go back to the original posts that they had, and we will no longer have an abortion service once COVID is over. So what needs to change now? Most importantly, we need the Department of Health to commission services, because we need staff, we need funding. There's no information on any of the trust websites, on any of the public health agency websites, or the Department of Health website on where you access an abortion in Northern Ireland. We desperately and urgently need telemedicine for COVID, but we need it for beyond as well. We need it for people in those kind of more marginalised situations that either are in rural areas that have really bad public transport, in relationships where there's intimate partner violence or coercive control, for disabled women, for migrants who maybe find it more difficult to have services already. And then finally, we really need to stop the cultural stigma. We need to recognise that the DUP hold an outlier view in Northern Ireland. Well over 90% of people surveyed in Northern Ireland support the decriminalisation of abortion. And yet the party with the most control over what we do with our bodies are the DUP, who are against any abortion in any circumstances whatsoever, and it needs to stop. If you or anyone you know or anyone comes to any of your organisations that need help, the first number to go to is Informed Choices NI. It's really important to point out that they are charity funded and they don't get any money from the Department of Health for their abortion line services. Alliance for Choice, if you're in the Northern Trust, we can put you in the direction of where you can legally get access to the safe abortion pills. If you have an illness that means you can't travel because of COVID, BPAS can, in really exceptional services or circumstances, send you pills by post. And then some people prefer to go to the services in Ireland, but it's really difficult at the minute with COVID. The bottom two organisations are the two reputable NGOs that we recommend people go to for the pills. If anybody wants to help Alliance for Choice, we have a petition there. That's a current petition urging Robin Swan to do his job. We've got a lot of information on all of our social media accounts. We do lots of fundraising with merchandise donations at our local given. We've also got all of the information that I had in the previous slide is on our homepage, and I Need an Abortion Now if anybody needs information and doesn't know where to go. And finally, we never seem to be out of the press, so links to all of our newspaper articles are there at the bottom. Thank you.
Thank you so much for that, Emma. And it's just so important that people are aware of the full impact of what's happening because of the health minister refusing to commission services. It's having a truly dire impact on so many people, but particularly marginalised women. So because there is no information out there and there is no training or guidance as well for health professionals, we're seeing women being tricked by groups such as Stanton Health Clinic, who are not what they claim they are, where they are intentionally holding women up to the point where they're getting beyond a certain number of weeks, so they can't actually access an abortion anymore. And sadly, there have been attempted suicides as a result of this, and a huge other range of horrendous issues that just should not be happening. People looked at Northern Ireland finally decriminalising abortion as something to be celebrated, and here we are now during a pandemic still not being given access to what we need. And arguably the only reason we have the small amount of access we do is because of the pandemic. So we just urgently need to work together on this and keep fighting on the issue. And just one thing to note, that again, common theme, what's lacking in Northern Ireland exists elsewhere. What's also been a common theme throughout all of this is how time sensitive these issues are. But there are further delays happening to the point where people are dying as a result. So it's just hugely detrimental to marginalised women. I am going to move on now to our final speaker, Kendall. So Kendall, can you hear me okay? I'm trying to see you on my screen.
Yep.
Yep. So I'm going to hand it over to Kendall, but I'm going to ask as well, just because sometimes there's issues with bandwidth, if people just for this session could turn off their cameras, and then we'll turn them on again at the end, because it would be great to get a group photo. But I'll hand it over to you, Kendall, as our final speaker of the day from Migrant NI.
Sorry, everybody. Thank you for being so considerate of my terrible internet connection. My name is Kendall Bousquet, and I am from Migrant NI. I'm going to just summarize a little bit about two reports that we have commissioned that touch a bit on the issue of healthcare for women from BME backgrounds. And then just very briefly kind of share some anecdotal information as far as concerns that have been raised from clients at the Migrant Center that we've been seeing. So the two reports that I'll cover, there's one that we commissioned. So primarily Migrant NI is a kind of a service provision based organization in terms of offering hate crime victim support, EUSS settlement support, and then we've got our LAVA project, which is kind of towards capacity building for new and emerging BME leaders. And then we have a project out in Enniskillen working with the traveler community there. When we do get little bits of funding that can go towards research, it's great to do that. And so these were just kind of things that came out of those situations. So we have, and I am happy to share them with Rachel, or if you want to email me, my email is kendall@migrantcenternI.org. So back in 2017, we published a report called Ethnic Minority Women's Access to Healthcare. And then the following year in 2018, a report on needs and issues of the traveler community in Northern Ireland that does cover healthcare. So the 2017 report on ethnic minority women's access to healthcare was a joint kind of production with the BME Women's Network at the time. And it was the summary of findings basically from a sample of 207 women from ethnic minority backgrounds across Northern Ireland. And so the findings of that kind of study survey found some common themes throughout it. One of them being the barriers that women from migrant and ethnic minority backgrounds face when accessing healthcare. So a big one of this that kind of was reoccurring in many women's answers was barriers in the form of language. So having to go through interpreters, and then perhaps interpreters sometimes not being available, concerns about kind of quality of interpretation, especially if it was a situation that happens a lot where a woman brings in her child to interpret for her. The survey found that non-English speakers had higher rates of saying that they were unable to communicate complex health needs, which is understandable. It can be difficult enough, if you and the doctor both speak the same language. But certainly if there is a language barrier, and women who had interpreters had higher levels of having misdiagnoses from their healthcare provider. Also, issues kind of as was brought up in terms of even knowing about obstacles generally for things like cervical screenings, bowel cancer screenings, any kind of women's health specific issues, that there is in particular a lack of knowledge of availability of these in migrant and ethnic minority communities. So lack of awareness of available services. BAME women have a lower uptake of antenatal healthcare, according to the Belfast Trust, and that often comes down to lack of awareness of the services available, difficulty navigating the system, and even getting registered. So some women reporting that they really had difficulty registering for a GP because they didn't have, the correct documents, versus, and that's a specific issue facing migrant women, because if you are from here, you were probably registered with a GP since birth. And also women reporting issues of occasionally of lack of cultural sensitivity, perceived racism or negative attitudes. So in particular, it's important to note that obviously women from ethnic minority backgrounds are not a monolith. The survey found that generally the highest rates of reporting of kind of women who found it, weren't reporting issues navigating the system. The highest rates were women from Southeast Asian backgrounds, and that comes down to the majority being from Filipino backgrounds and already working in the health services themselves, and so maybe being a bit more knowledgeable about the system and how to navigate it, versus Black African and Caribbean women reporting the highest kind of levels of issues in being able to access services and navigate the system. There are a few different factors that contributed to that. Within the sample population, women from Black African and Caribbean backgrounds they were the lowest proportion of English speakers, highest proportion of refugees and asylum seekers, twice the rate of unemployment, lower household income, lower educational attainment. So obviously lots of structural factors contributing to that, which needs to be viewed specifically as particular issues that are facing Black women, and particular healthcare needs there. In addition to those barriers, there are also issues of immigration status, kind of serving as an obstacle or precluding women from seeking healthcare. So women who didn't know or who weren't sure of what healthcare entitlements they had because of their immigration status were significantly less likely to access healthcare services, and this would be obviously a particular issue for kind of preventative services, and like the screenings that have been mentioned would cause really low rates of kind of accessing those. again, unlike this is an issue that faces specifically migrant women, and wouldn't, face women who are born here, because uncertainty about healthcare entitlement is an issue to migrant and ethnic minority women. So the report goes on to kind of summarize particular factors or kind of particular groups that had additional difficulties in accessing services. So refugees and asylum seekers had the most difficult and the most negative experiences with the healthcare system here. And that came down to factors like ease of registration, not finding their care to be culturally sensitive, and the most difficult issues with communication. Women with lower or no formal education had greater needs than the rest of the sample. In particular, those needs were greatest for issues like gynecological care and sexual health care. And so this would be an issue that would disproportionately affect women, maybe from asylum seeker backgrounds, coming from a situation where they didn't have access to formal healthcare. And so that report kind of does a summary of the obstacles and kind of experiences of a sample of women across Northern Ireland in terms of accessing healthcare and healthcare inequalities. We also, so the kind of limitations of that study were that there weren't really sizable representations with the traveler community, but then we did commission this the study on needs in the traveler community the following year, but also that the study, as far as the resourcing that was there, being able to mitigate the access gap to the Roma community to include a sizable proportion of Roma women wasn't there, but we do know that Roma women in particular would face any of these obstacles to kind of the highest levels, because they are some of the most excluded groups with terms of kind of accessing the system and exclusion from the system itself. So the study that I'll talk a bit now, that was commissioned by Migrant NI on needs and issues in the traveler community in 2018, and then was carried out by the Strabane Youth Access Engagement. It covered different factors like accommodation, education, and then one of them was healthcare. The findings from healthcare, really across the board, it's shocking stuff, but maybe not shocking if you are aware to the extent, the level of discrimination, exclusion, and just kind of downright racism and mistreatment of the traveler community here in Northern Ireland and across the island as well. Really devastating figures there. 89.5% of respondents of this survey agreed to the question that they or someone living in their household had a disability or a long-term illness. So again, just shy of 90% of respondents. And then health outcomes were just generally found to be much poorer than the general population along physical and mental health markers. It found that the traveler communities, the prevalence of anxiety was 3 times more likely, and depression was 2 times more likely, and a particularly heartbreaking statistic found that people from traveler communities are 7 times more likely to die by suicide than the general population. There are, of course, as you know, in all of these situations, particular disparities for women. Women from traveler communities are expected to live 12 years less than women in the general population. And there was excessive evidence of miscarriages, stillbirths, and neonatal deaths in the traveler community when compared to the general population. High rates of maternal death, really high levels of health disparities within traveler communities and for women from traveler backgrounds in particular. Really, again, the issue of obstacles to care come up. So obstacles that were reported in from respondents in this kind of study in particular stated that they had difficulty registering at surgeries because they maybe weren't able to provide proof of a permanent address, obstacles around poor literacy, and really lots of reports of anticipation of discrimination being a big deterrent, kind of like expecting the treatment to be poor, so why subject yourself to what you think will be a traumatic and abusive experience in and of itself from the healthcare service, and then concerns about lack of cultural awareness about the traveler community within the healthcare system. So as I said, those were just the kind of most relevant findings from those two reports that Migrant Center and I commissioned. They would have been the most kind of recent ones that we had done. As far as what we're seeing day to day that is relevant to issues of women's health, I think a lot of people don't realize, and we're seeing this with kind of clients like being concerned about this and reporting that they're having issues with this, is that maternity cover is not an exempt provision under the NHS. You have to be considered ordinarily resident, and there's a whole definition as to what that means, or an EEA national, but so that there are, a significant portion of people who would not be covered for free maternity coverage under the NHS. And then also, kind of specifically COVID related, there's been a big delay in assigning national insurance numbers to people. That's caused a lot of confusion around healthcare entitlement. And then of course, having a national insurance number is crucial for things like, maternity coverage, for that to be paid out, for bereavement support payment, which we know kind of disproportionately affects women if it is like a situation where a partner dies and that was the main source of income. So people are being, there's a lot of kind of present confusion and worry around the significant delay in the assignment of national insurance numbers in a way that specifically is affecting people from migrant backgrounds. So I know that's a lot of information, but oh, sorry that we're gonna have to finish it up there. Sorry, but so that's me.
Thank you so much, Kendall. And again, as I said at the beginning, we could have definitely dedicated a full webinar to each of these topics. And there are so many common themes across all of the topics. And again, with what you're covering, it just shows that some of the most marginalized groups, again, are suffering even more during this pandemic. So I know you covered a range of issues to do with race, but also migrant status. And we have a few questions as well around, so we've one from Caroline Smith. Kendall, is there much help with interpretation in health services here at all where that is needed? So I don't know if you want to comment on that before we finish up.
Sorry, I muted myself. So what we find with interpretation services, and this is across any kind of the kind of services from statutory bodies, is that there's a policy on the books that interpretation services have to be provided either in person or over the phone, what we find in practice is that that's not always the case. You know, in the best case scenario it is, but sometimes, you know, people, like I said, you know, maybe need to bring a friend or, you know, bring their child to interpret for them. Also, this is a whole thing, we could talk for a while about interpreters, but there are whole issues of kind of cultural dialect, like especially like people coming from conflict backgrounds, like just a whole kind of nuanced things that can make sharing information comfortably difficult. And you'd see that specifically with populations that maybe have a smaller proportion of the population, and just experience-wise working, you know, in refugee resettlement as well, that there have been issues of really the only interpreters available being male, and the issue at hand is something like domestic violence or maternal health, or something that, you know, really isn't as comfortable to have a male interpreter handling. So the answer is yes in theory, but in practice it's more complicated.
Yeah, thank you, Kendall. And that tends to be another common theme, that yes, technically we have legislation that provides for these different areas, but in reality that doesn't happen. And with COVID as well, I know there's been huge issues where you're only allowed one person in the room, so having an interpreter with you is challenging. And then when we look at other things as well, for example, maternal death rates, the UK is one of the worst in the world for Black women's maternal death rates. You're 5 times more likely to die than a white woman while giving birth. So it's just huge racial discrepancies that exist. And I know within WRDA, Paula and the women that she works with in particular, they do work a lot with interpreters, and not only language interpreters, but also, for example, sign language interpreters for the deaf community. There's only 24 BSL interpreters in all of Northern Ireland. So while it says that you should have an interpreter, it's just not possible a lot of the time. But thank you so much for that overview. And again, Kendall is a member of the Women's Policy Group and contributes significantly as well to a lot of our research and publications. So what I will do after this, because I know we didn't have time to do the full Q&A that we wanted, but if anyone does have any questions that they want to ask of any of our speakers today, I'll send it out. I'll send it to the speakers if you can email them to me. I'm also going to be sending out a survey to all participants asking for feedback on today's session. So that will give an opportunity as well to ask some of the questions that you didn't necessarily get the time to ask today. But I just want to finish up by thanking all of our speakers. It was absolutely incredible to hear from all of you. And again, you know, we could have talked at great length about so many more of the topics and even just some of the parts that were mentioned by each of you today. But time didn't allow for it. But I do hope that it provided a useful overview to you all who attended on the additional health impacts that COVID has had on marginalised groups and why these have worsened significantly because of COVID. Because I know when we talk about health, we've mostly been talking about the health impact of COVID itself, which is severe. But there's been so many other additional barriers and huge impacts that we need to consider. So just before we go, I was wondering if people would mind turning on their cameras. I'm going to just take like one quick photo of us all here today, just for social media purposes. If you don't want to turn on your camera, that is totally fine. Excuse me. But I'll give everyone a second just to do that. While I do that, I'll read out a note that we did get from Megan Fitzsimmons. So Megan works with the UK-wide representative healthcare organisation. And there's a frustrating misconception within the NI office that racial and ethnic health inequalities are exclusively an English problem, given the comparative lack of diversity within Northern Ireland, which only ultimately manages to further and undermine the issue. I completely agree with this, Megan. And when we look beyond health, if we look, for example, at how the Black Lives Matter protests were handled in Northern Ireland through the active criminalisation and prosecution of protesters, we can see that, you know, it's not an issue just for the US or GB, it exists in Northern Ireland. And it exists hugely in Northern Ireland. There are more racial hate crimes now than any other type. So totally agree with that comment. So I'm just going to take a quick picture here. So if you all want to look at your camera and smile. Oh, there's Liz Law. I'll take another one.
There you go.
Great. Thank you so much, everyone. And thank you again to all our speakers. Really enjoyed this event today, and I learned so much from each of you speaking already. So I hope we can continue conversations like this through our other webinars. So we have got another webinar on the 26th, looking at violence against women specifically, and we have another one on the 10th of December looking at Brexit, a Bill of Rights, and women's human rights. So thank you, everyone, for today. I'm going to end the call here. But I really appreciate all of you attending and all our speakers. So thank you.
Thank you.
Thanks so much for having me. See you soon,
Thank
folks.
you. Bye.